Professor Patman because she gives the perfect bridge to my talk, as she was talking about chronic kidney disease. So then when chronic kidney disease reaches this final stage, when we're talking from end-stage renal disease, the best therapy option would be kidney transplantation. And what I would like to show you here is what can we do in future to predict the organ quality or to predict the graft function. So the problem in organ transplantation, what we have in general worldwide, is that the organs are not enough. So waiting lists for all types of solid organ transplantation are becoming longer and longer, and especially for kidney. And it is definitely the best treatment we can have. So we have to use more extended criteria donors. So we have to consider them to have more organs for transplantation. And this is not because the transplant surgeons want to do a higher number of transplantations. This is because when you compare the outcomes of kidney transplantation, even with what we call extended criteria donors, they are significantly better for the patients as compared to the ones who are staying on dialysis. So what can we do now to have a tool to predict the status of the graft? And it's not only about that if we know, can we transplant it? It is good for the recipient, it would be a benefit for the patient, because if we can prevent a primary non-function or a very low quality function for the patient, then we can prevent giving harm to the patient, as the patient needs to get some immunosuppressive medications and they are not without any side effects. So what can we do? So this is what you can see here. These are 2 kidney biopsies, and these are colorful pictures, always pink and violet, and what they show us is a static situation. So this is the status quo of the kidney with all the different types of, you can see here, so the round figures is our filtration part of the kidney. This is only showing a chronic damage or the status quo. So this picture cannot show us the viability, but at the moment, this is the best what we have. The other problem is receiving this picture, so this histology stains, take some time. So, and we are transplanting most of the time in the middle of the night, and not all university hospitals or not all transplanting centers have a pathologist around. So it is a time-critical event what we are waiting for, because when you're waiting for the histology result, if this is a good organ or not a good organ, can we transplant it, you will lose another 1 or 6 hours, and the cold ischemia time will become longer. And the cold ischemia time, so this is the time when the organ is coming out of the donor before we reperfuse it in the recipient, so before the blood is going through the recipient. So what we were now thinking of, what can we do that we can predict what's really going on in the kidney? So when you think of how a kidney biopsy is done, this is like drilling a hole in a key, in a tree. So this is called dendrochronology. And what we can see in this, so it's telling us a story. And in the trees, it's telling us the story, how old the tree is, and in which condition the tree is. So we were thinking about, let's call it biopsychronology, because taking a needle biopsy of a kidney is like, yeah, you drill a hole in and you try to get the best information out of it. And these are colorful pictures, and I will come to this later. So we want to see what's the story of the kidney. And parts of this, so here you can see what's the principle of biopsychronology is. Biopsychronology, the name was invented by our colleagues from Innsbruck University. Is a group about Martin Hermann. Martin Hermann is like, we would call him a Mr. Confocal microscope, because he is amazing. He does amazing work for us. And he tried in a rat model before if the life staining and the evaluation with the confocal microscope would work. So this was very successful. They published this as biopsychronology in the experimental model, and we now wanted to bring it into the clinic as a translational work. So here the principle of biopsychronology, you take the needle biopsy, then you incubate it with the life stains. So we used 3 different stains with cyto16. So it's the green. You can see this is staining the cells which are alive, and the dead cells. The PI is the red color you will see, the staining all the dead cells, so the apoptotic, the ones who are not active at the moment. And the blue type is we need to use because we want to see what's the tissue about, so what's the stain of the tissue, or if there is a high grade of fibrosis, what is not that perfect for the kidney. So these are the storytellers. What I showed you, the propediomyodin, the red color. So these are not the non-functional cells. The greens one, the cytotoxin, are the functional cells. The VGA is the tissue, the condition of the tissue, and then the last picture on the lower right can show you what is the kidney function about when you merge the colors. So these were the first research highlights after our experimental work. And so with all this information we got, and with some experiments before, we started a prospective clinical trial in Innsbruck Medical University. It's in Austria, and we started this in October 2015. And so far, 18 patients could be included in the trial, and we were accepting all patients for the study who received their first or a retransplant from a brain-dead kidney donor. So there was no score around to quantify what the quality of the kidney is. There are some scores around for histology called Remuzzi score. They are all scores for chronic kidney damage, but as we know, when you have it, these are showing us damages, so we cannot change atherosclerosis, for example, in the kidney. So we tried to develop a score, and so the three different parts of the kidney were put in the score. So the glomerulum, which does the main filtration, and then we have the system followed by the glomerulum are the tubules, and the tubules is important for reabsorption electrolytes, for example. So and we said, okay, when we have more viable cells than dead cells, it's a 1, and so on. When there are more dead cells than viable or living cells, then it's a -1. And so we had an overall score from -1 until up to +3. So the lower the score, the worse the kidney is. What we got so far are the 18 patients we transplanted. So 4 were retransplants. It's always an important information to have, as the recipient who had already an organ transplantation before is sensitized, and it's more likely that they have a delayed graft function. But we wanted to include everyone, because what's happening in a clinical practice, you have the sensitized patients, you have the retransplant. So it's not, our aim was not that we figure out who is the recipient doing. We wanted to do what's the organ doing in the recipient who is just coming up for transplant, and who is the next on the waiting list. So 6 recipients were women. So the median recipient and the donor age were also about 50, late 50s, early 60s. The cold ischemia time, so this is the time in which the organ is without oxygen, so the organ is not active, it's cold stored, it's on 4 degrees Celsius, was about 14 hours, so up to 20 hours. And then we are coming to our score. And the mean score for our real-time imaging, so it's the score which could be -3 up to +3, was about 1.2. And 7 patients out of them had a delayed graft function. So this is defined as the need of at least 1 dialysis within the first 7 days. So there are lots of definitions around, but we use the most common one, which is used in everyday clinical life. And the mean score in the patients who developed a delayed graft function, so the ones who did not have a perfect kidney function immediately, they had a lower score compared to the ones with initial graft function. Of course, with 18 patients, so we want to include 40 patients in the study. And this is not a significant difference, but it shows us that we are on the right way. So we will see what is happening at the end, but what we could see so far, so it's worth doing it. And it is an easy assessment. What's the good thing is, so we are very lucky because we have a person available who can do the confocal microscope and the live tissue staining for us. And the good thing is that the live stains, so this PI, the cytotoxin, they are not harmful for the kidney tissue. So we can use exactly the same tissue for immunohistochemistry and for histology. So we get exactly the same results from the pathologist, as the result from the pathologist will give us the same information about exactly the same part of the kidney, so which is very helpful for us because we are evaluating exactly the same point of the kidney. So these are now some examples and how our pictures look. And so the first thing, the glomerulum, so our filtration apparatus in the kidney. This is from a these are pictures from a kidney who was for 98% viable, so according to our score, so you see a lot of green. This is then the first part of the tubulus system when the electrolytes are reabsorbed. This is the second part, the distal tubulus, which is a little bit always forgotten in the, not for ethnologists, but researchers, we want to know if there is an acute tubular injury or not. And this is the overall view with the tissue. So it's fine because we see not that much blue, so we have not that high level of fibrosis. And what else can we do? So this is just red and green, but this TMRM, this is the short version of a stain, which can give us information about our power plant in the body, so these are so-called mitochondria. And the mitochondria, so our power plant is important for the energy in every cell. And this is one, so this is then the next project, because we tried this in a few kidney biopsies, and we can stain them. We can see if this mitochondria, and they are especially in this, it's proximal tubulus, so in this important part of the kidney, we are so interested in if the reabsorption is functioning or not. So this is the scientific description for it. So we can stain the mitochondria and if they are alive or not, if they are functioning or not. And this is an interesting question, especially for at the moment, as we have only the option to cold store the organs. So in the future, we are working on bringing the organs back to normal body temperature. But this is at the moment a staining we can use for the standard of care, how organs are preserved, kidneys are preserved at the moment. So to conclude, so the biopsychronology is a feasible and a safe approach. So we didn't lose any kidney tissue. The real-time imaging gave us some detailed information about the organ quality. It is, as I mentioned already, possible to examine exactly the same area, which is sent for histology. So we really can compare the different scores available. And what's one of the most important things as well, especially when you have a transplant patient, you called him in, and you have to tell him then, oh, we cannot transplant you because the organ is not that good enough. Or we can say, okay, we told you before, it's a critical donor. It might be not the best to use, but we could evaluate it, and we can tell the patient what's going on in their organs. So thank you very much.